Created some interesting expectations in our society, and as healthcare providers we're dealing with this on a daily basis. One is that there's immediate access to care. There's no waiting, or there shouldn't be. That there should be no complications when you come for healthcare. That there certainly should be no mortality. I always think it's fascinating how we deal with mortality in healthcare, as if that's something we can avoid forever. But last time I checked, mortality for each of us individually is 100%. It's only a matter of when. And then lastly, the expectation that somehow we're able to create perfect outcomes. You know, we work in healthcare where it's a group of people taking care of other people, and I'm here to tell you that healthcare workers are no more perfect than anybody else, and yet that's an expectation that we have in our society. To a large extent, Medicare has been seen as a positive thing by providers. Initially, Medicare paid for charges. In other words, doctors and hospitals no longer had to pursue payment from patients, but instead they could go to the federal government, called Medicare, and Medicare paid what we call bill charges, retail prices. In recent years, perhaps over the last 20 years or so, Medicare began to limit what it would pay to providers, and that difference between charges and what Medicare would pay us is I'm going to call a shortfall. That shortfall has reached fairly significant proportions, and I'll talk about that in a minute. But as a result of that shortfall, providers, doctors, and hospitals began to increase their charges to private payers, patients, insurance companies, to cover the shortfall for Medicare and Medicaid, which of course has resulted in health insurance premiums going up fairly dramatically in recent years. In Powell, our Medicare shortfall has now reached 44% of charges. And in 2009, it accounted for almost $16 million in services that we provided and will not get paid for by Medicare. It's about 30% of our volumes in Powell. It's a significant problem. And the concern partly that I have is with the increasing Medicare population, we're all getting older, that shortfall will continue to grow. So here's some...
There's a problem. Rod touched on this, but the healthcare expenditures as a percentage of our gross national product is eating more and more of our expenditures. You know, right now it's over 16% of our gross domestic product goes to healthcare. And as a country, that's a tremendous burden on us. It creates situations where our products are a little bit more expensive than other products from other countries.
Another challenge in our current system is that providers are paid for the services that we perform, and under the current system, surgeries and other procedures are paid at a higher rate than simply primary care services. So not surprisingly, the incentives are there to perform more. Heck, if I get paid for an x-ray, but I get paid even more for doing 2 x-rays, why wouldn't I do 2? And although I don't think that we're evil as providers, that's certainly the incentives that exist in the system. And then another incentive is physicians are incentivized to become specialists and not primary care physicians because they get paid more as specialists. And so not surprisingly, we're beginning to see significant shortages of primary care physicians throughout the country.
We see healthcare costs rising at double the rate of inflation. As Rod said, USA is the highest per capita healthcare cost. Health outcomes are not a whole lot better than you see in other countries. We have a lot of uninsured, 48 million. People are self-denying themselves health care. And as much as this bothers us as an industry, you know, we don't necessarily like everything about health care reform, but we hate even more the fact that there are people that just aren't getting care. People under reform, you know, as Rod said, wait times will increase. So really, the trade-off I've told people is, under healthcare reform, sure we'll have access, but we'll have longer wait times. So, you know, what's going to be the cost associated with that? What's people's health ramifications going to be with longer wait times if they can't get in to see the specialist when they need to and have that cancer treated in as timely as a fashion as they can now? How is that going to affect people's health care versus the fact that some people just don't go in to see the doctor now, and how does that impact health care?
Now, what we do in healthcare reform depends on the answer to that basic question. Is it a right or a privilege? And if it's a right of every citizen to have access to healthcare, one option should be, maybe, that it should be a government-run system. I'm not promoting this. I'm just giving you one one group of thinking, I guess. And under a government-run system, government-owned hospitals and providers would exist. And of course, this is the type of model that exists in many European countries. What it results in, of course, is much higher taxes. And I've read stories like in places like Sweden where the tax rate is 60 or 70%. So when I'm talking about much higher taxes, it's like really high taxes. But I've also heard the argument that there's no insurance premiums for health care, and therefore those high taxes are offset by health insurance premiums. That there is free care to all. Now I put free in quotation marks on purpose. And the results sometimes in those countries are that there are long waits for care and there's rationing. Okay? Now if healthcare is a privilege, and if we go to that particular extreme, then people with money would get more and better care than people who don't have money. And that some people who don't have any money at all don't get care at all. And that providers, meaning doctors and hospitals, would compete for patients, but we would only compete for the paying patients. No one would compete for patients who don't have any money, right? And that there would be different levels of care. That if you have money, you get a higher level of care than those who don't. And one could argue that that's rationing of care as well. Now, part of me would tell you that's exactly what exists in our society right now. If people have insurance, they get access to care where people who don't have insurance may not. But if we truly go to the extreme that it's a privilege and only people that have money can get care at all, it would be different than what our current system is. Because reality is we have kind of an element of both in our current system. And perhaps society has a responsibility to provide a basic level of care without an obligation to provide all care.
Things that are unknown on the insurance end of how it will affect and how it will change, and these changes are so far off. There's some things, yes, that will go into effect right away in September, but even on the quotes that we do now, in red, bold letters, it says, due to the Patient Protection and Affordable Care Act, plans issued after March 23rd of 2010 may receive additional benefits and corresponding rate increases as soon as January 1 of 2012. So on all the business that I write now, where I used to be able to lock in premiums and do things for customers, we just can't do that anymore because insurance industry doesn't know really how this is going to affect their pricing either.
My personal fear on this is that that's going to lead to a single payer system eventually. That the system can't keep going like it is with us covering our costs by passing it on to the non-government payers. So